Right, Ingeborg, thank you very much, and thank you for the invitation to speak about trabeculectomy revisited. Now, we've just had a session about artificial intelligence. So what does the ophthalmologist do? You ask AI about trabeculectomy. And what does AI say? Well, trabeculectomy remains a gold standard, yet declining glaucoma procedure. And secondly, the number of trabeculectomies performed by fellows has shown a significant downward trend. Now, at that moment, I had to be really brave and resist the temptation to ask AI to do my talk, be- because I think these are two fair statements. But are they really fair and are they true? Well, I looked at the literature, and yes, the number of trabeculectomies per surgeon in the United Kingdom is declining. Now, it's a little bit too small, but a few years ago, they did 45 procedures per year, which is not a lot, one per week. And now they are down to 18. Yeah. Okay, this is the green line. And the blue and the red line is first and second surgeon. We don't have that in Germany. There's only one surgeon. So from one per week, which is not a lot in 2014, to one every 3 to 4 weeks. Now, MIGS at the same time have a large increase. And this on the left-hand side is no surgeries before 2016, and now it has gone up to 85 surgeries per year. So 4 times now, 5 times the number of trabeculectomies. So Google was right, I think. And Google goes on, while MIGS and tube shunts are increasing, trabeculectomy is still used when high pressure reduction is needed. And studies suggest a decline in the procedure's use despite increasing need due to aging populations. And I'll come back to aging, the phenomenon of aging population, what that means for our patients at the end of my talk. So why on earth, if Google says it's used with high pressures, don't we use it so much? Well, Esther has made my task easy, but it does have a bad reputation. So there is experience necessary, quite obviously. It's not something which you just do or apply. You need to dissect the conjunctiva, the sclera. And if the number of surgery goes down like that, there is no experience among young surgeons. Then there's follow-up necessary. Ingeborg always says, if you do trabeculectomy on a patient, you need to be willing to get married with him or her for the next 4 weeks. And I think that's more or less true. And of course, there are complications, like, for example, external fistulation. So there is a vicious circle. Experience is necessary. We do fewer surgeries, and then you have less experience, and then you have more complications. And there are other complications, external fistulation. The IOP may be too high, it may be too low, and there may be other severe problems. Now, luckily, Julia Stingel is going to cover these. I don't have to, but I can tell you they can be solved. But there may be really difficult filtration blebs, or there may be disasters such as expulsive hemorrhage. Now, we see them very rarely, but of course, you then are more hesitant to do that. And very, very rarely endophthalmitis. I think we see it about once a year, but we are doing many, many surgeries. So having all that in mind, well, actually many people have said trabeculectomy is the worst of all glaucoma surgeries. Well, apart from all other surgeries. So it's really bad, but the best of what we had. But is that really true? And now we have a discussion, and that is good. We have a public discussion in ophthalmology about trabeculectomy. So, for example, an editorial, is minimally invasive glaucoma surgery killing trabeculectomies? I'll give you the answer, it's not. And we just heard about trabeculectomy must survive, was said in an editorial. And I quote Esther Hoffmann, why is trabeculectomy not as bad as the reputation? She gives many arguments for that. And perhaps even more important, how do you learn to do trabeculectomy? And Alexander Schuster investigated that and showed how it can actually be learned and taught. And of course, there are advantages of trabeculectomy. You just heard about some. I will repeat some. It does, of all the glaucoma surgeries, on average, have the best IOP lowering. I won't go into the detailed studies, but that's true. It has been shown by many studies. It's superior to all non-penetrating procedures. I think I've won all the disputes between penetrating and non-penetrating surgery. It's superior even to glaucoma drainage devices. And there are long-term results available for 10 years, 15 years, even for 20 years. And one important thing, it's good value for money. You do need a surgeon and you do need an operating room, but apart from that, you only need a blade and a suture, and that's really all you need. And we save about €1,000 for anything that we do additionally. But most important, it gets you where you want to be with serious patients, with advancing patients. And I quote this from the Advanced Glaucoma Intervention Study. It is a study that was done in the 80s to compare trabeculectomy with argon laser trabeculoplasty. Now, this is not the thing I want to go about, but there was a post hoc analysis. And the post hoc analysis looked at these 800 patients who were in the study and compared the results over the follow-up and comparing those patients who always had pressures below 18, so 17 or less. That's this curve. And going up means the visual field became less good. And if sometimes the pressures were higher, then this is this green curve. And if in 50% the pressures were higher, this is this curve, and even more, then it is this curve. But when it analyzed what the mean pressures were for these groups, it showed that for those patients who always had 17 or less and did not progress, the blue curve, the mean pressure was 12.3. For the other groups, it was 15 and 17 and 20. Well, actually, until then, I was quite content with patients having pressures of 15, but now I'm not, because I know that they can progress. Not everybody, but those already with advanced damage and those with progressing. So that is where we want to go. And so I think their trabeculectomy is advantageous. But we've just seen the film about the PreserFlow. Does that not render similar results? Well, and will the PreserFlow microshunt impact the future of trabeculectomy practice? Well, I'll show you some slides from the study that you have already just seen, and it's on very small print. But actually, the difference between trabeculectomy and the PreserFlow group, PreserFlow microshunt on the left, trabeculectomy on the right, was only significant for hypotony because there was less hypotony, 30% and 50% for trabeculectomy. So that was the only advantage of the PreserFlow, standardized outflow. And there were more post-operative interventions for trabeculectomy, but more reoperations for the PreserFlow. But let's look at the pressure results, and you just saw that already. So after 2 years, and we've just seen the 5 years result, the pressures in the trabeculectomy were about 10 to 11 and about 14 in the PreserFlow group. Just think again of what the Advanced Glaucoma Intervention study showed. So 12 is not reachable with the PreserFlow. It's more close to 14. And those progressed. So PreserFlow may be a good operation, but not for advancing glaucoma. It will not replace trabeculectomy. So therefore, what are the long-term results? For PreserFlow, we've seen 5 years results. Here are the MINDS results for 10 years. And we do actually have some 20 years results. So once you are over the first year, I think your chances are quite good. But then there is the problem of these hypotonies and also the reoperations. And Is that realistic? You have hypotony in 50% of cases? No, it's not. And I'll show you a technique that avoids these, and it's the techniques we have been using for many years, adapting, of course, but basically it is that. So, and this film shows you trabeculectomy. So, as I said, you need very little things. You need a blade here and a forceps, and we always open at the limbus. So, um, uh, dissect a little posteriorly. We always use mitomycin C in 100% of cases. I've done so since mitomycin C was available. And then it's rinsed. And now something very specific. I make a cut here into the cornea. Now, this is not for cataract surgery, but it is to later on anchor the suture to suture the conjunctiva. Then the dissection is into the clear cornea. Now, although it's called trabeculectomy, here is the trabecular meshwork. What you do is a clear cornectomy. It's not important to cut out the trabecular meshwork, but do the dissection further anteriorly, and there are far fewer complications. Now it's the suture of the scleral flap, and it's important to do the posterior stitches first into the sclera, then through the scleral flap, and then tie the knot. That leads to the knot being underneath the scleral flap, and it leaves a little space between the scleral flap and the sclera, much like a small stone underneath the door. Then the door doesn't really close totally. So, and here is now the conjunctival suture. We go in through the conjunctiva, into the cornea, through the groove, back again through into this conjunctiva, and then it's the first knot. And then you go into the conjunctiva, into the cornea, take it forehand, come back through the conjunctiva, and pick up the suture here. And therefore, it's a continuous running suture. Now, it looks complicated, and if you just do one suture here and one suture there, it is always watertight at the end of the surgery. But in 50%, it's not watertight on the following day. So this takes 5 minutes more, and with some practice, 2 minutes more, but it saves you hours and hours wondering what you should do after surgery. And then you pump up the anterior chamber and you see whether it's actually watertight. So this is a technique that has far fewer post-operative complications. Of course, we have wound healing and the problems with that. Of course, we have other long-term problems, but that reduces the number of hypotonies and post-operative interventions. Now, finally, I would like to recommend that this surgery should be done far, far more often. And why is that? And I come back to something that I said initially. Google said it. We are an aging population. So if a baby is born right now, it does have a life expectancy of about 80 years. Now, you are a little bit older, so once you've reached, let's say, 40, then your life expectancy is now almost another 50 years. So we get much older than we assumed. And how are we serving this population? Now, actually, ophthalmologists gain a lot from the aging population. What this shows is a comparison of what patients we see at what age. So, and the dark line, that's for men and that's for women, is the population, the number per visits per 100,000 that we see. So we don't see babies, then we see them up to 5 years for squints, then we don't see patients, and then at the age of 55 or 60, it goes up. And it goes up much, much higher than, for example, for ENT or dermatology. So the load of disease in ophthalmology increases much more than, for example, also cardiology or even cancer. Very few people know that. I think we all should know that. So we benefit from the demographic change. Now, when we see these patients, well, do we really see them? This is the age of 80. And what happens after that? We stop seeing the patients. They don't come to us. We can't visit them at home. They have problems. So we really lose the patients after the age of 80. So whatever we do for glaucoma, whatever we do for treatment, if you don't see them, we won't prescribe drops, they won't come. They need a definitive answer to their problems. So I think just for the elderly population, surgery, definitive surgery is a good idea. So in summary, trabeculectomy remains the most effective glaucoma surgery when it comes to intraocular pressure. Experience is necessary, follow-up very important, excellent chances for young surgeons. And if you have any questions, come to the European Glaucoma Society Congress and you'll learn everything about it. Thank you very much.